Good morning. Thank you very much, everyone, for the Big C chats and Life to the Max online for having me here. Today, I will be talking about the role of radiation therapy in maximizing survival for cancer patients. So, I have no disclosures. This is the outline of my talk for today. First, I will be defining what cancer is and the usual management for cancer. Then I will be talking about what is radiation therapy and what are the mechanisms of action, why we do radiation therapy. Then I will be talking about the two main components of radiation therapy. First is the external beam radiation therapy, and second is the what is internal radiation therapy or brachytherapy. I will be showing some sample cases that those of the patients that we have treated, and then what are the usual survival rates for patients, and what are the common misconceptions on radiation therapy. So first, what is cancer? Cancer is the uncontrolled growth of abnormal cells in the body. The cells in our body usually live, and then after their time would die. So there's a natural birth and death of our cancer of the usual cells in our body. But cancer is the uncontrolled growth of these abnormal cells in the body. And cancer develops when the body's normal control mechanism is impaired. The old cells, they do not die, and instead they grow uncontrollably, forming new and abnormal cells. So there is an uncontrolled growth of these cells. And when there is an uncontrolled growth, it may form a lump, such as a tumor, or in certain instances, there are no lumps, such as in leukemias, they are in the cells of the body. So what are the most common cancer sites? Number one usually is the lungs, followed by the breast. And then also we have colorectal, we have uterine and cervical cancer, we have prostate cancer, and we have head and neck cancer. Of course, there are also other cancers, such as you have cancers of the blood. You also have cancers of the bone. You have cancers of the soft tissue or the muscle. So there are a lot of other cancer sites, but these are the most common ones. So how do we usually treat cancer? Treatment of cancer should be a multidisciplinary approach. We are always advocating a multidisciplinary approach. Not one specialty should be the only, not one specialty should be the treatment. It should be a modality, a multimodality approach. So we have here the surgery, which is the actual removal of the tumor or direct removal of the tumor. And then we have chemotherapy done by medical oncologists, where they use drugs and other chemicals to kill the cancer cells. And then my specialty is radiation therapy, wherein we use ionizing radiation, such as X-rays or radioactive sources, to kill these cancer cells. Now, also included in cancer management we have pain specialists. Of course, we have the pathologists who will tell us what this cancer is about. We have radiologists, which defines the tumor targets, which defines using CT scan. We also have nuclear medicine specialists, wherein we use the bone scans and the PET scans. And we also have nutrition, okay, because the nutrition is an important component in the management of these cancer patients. So I will mainly be discussing my specialty, which is radiation therapy. So what is radiation therapy? It is the use of a high energy radiation to damage the cancer cells' DNA, destroying the ability of these cancer cells to divide and grow. As if you can remember, when we were talking about cancer, it's the uncontrolled growth of these cancer cells, so they do not die. So with radiation therapy, we destroy the ability of these cancer cells to divide and to grow. And we have different modalities of doing that. We have what we call an external beam radiation, right, which is delivered via machines called the linear accelerators or a cobalt machine, or via radioactive sources, wherein we place these sources of radiation directly within the tumor. Okay. Now, not all cancer patients will actually need radiation therapy, but more than 50% of these cancer patients within their time frame would be needing radiation therapy. So, what is the mechanism of action of the radiation? How does radiation kill cancer cells? The target of radiation is the DNA of these cancer cells. So it targets the DNA, and there are two mechanisms by killing it. So one is direct action of radiation therapy, wherein this is the source of the radiation. It releases a photon, and directly it hits the DNA of the cancer cell. So the radiation therapy is absorbed, it interacts with the DNA, which results to cell killing. So there would be the uncontrolled growth would stop, and eventually the cancer cell will die. Or the second mechanism is an indirect action of radiation therapy, wherein the X-ray or the photon would be absorbed and it would interact with water. Of course, we know that water is a major component of our cells. And after interacting with the water, it would produce free radicals. And these free radicals would now result to the cell killing, making these cancer cell unable to divide, okay, and eventually stopping its growth. So for radiation therapy and for any cancer treatment for that matter, there are always two intentions, okay? We would in treating a cancer patient, would it be for cure or would it be for palliation? When the patient has a cancer that has not yet spread to other parts of the body or it is not yet stage 4, the usual intent of treatment is curative intent, meaning we want the patient to be cured of cancer and we want the cancer to not come back. But there are instances when the patient would come to us with already a stage 4 cancer, meaning it has already spread to other organs, and there is already a very hard time. We will have a very hard time of trying to eradicate all of these cancers. And for these patients, radiation therapy is still done, but for a palliative intent. And what does that mean? It means that we want to relieve the patient's pain or alleviate other symptoms, such as, for example, bleeding, for example, difficulty in breathing. Okay, so we can use radiation therapy to alleviate that. If there is a constriction, meaning if, let's say, there's a spinal cord compression, the patient cannot walk, so we use radiation therapy to treat that, and if it responds, then the patient will be able to walk again. So this is the palliative intent. So not all patients would have undergo curative intent, because if the cancer has already spread to other organs, it will be very difficult. So it could be a curative intent or a palliative intent for the treatment. So what is the goal of doing radiation therapy? So first, the patient would not just lie down and have the radiation. We have to deliver a precisely measured dose of irradiation to the defined tumor volume. Okay, so we have a defined tumor volume. Where is that target? So we have to know where the target is by using CT scans, MRI, or PET scan. And with that defined tumor volume, we would be prescribing a definite radiation dose. But within that target volume, of course, there are surrounding healthy tissues. So we have to spare these normal tissues. There should be a minimal damage to the surrounding healthy tissues as possible. Okay, so if we are able to deliver the precisely measured dose of irradiation to the defined target volume and with minimal dosage to the surrounding tissues, our goal is to eradicate the tumor and provide these patients with a high quality of life and, of course, the prolongation of their survival. So, what are the principles of radiation therapy? First, of course, as I said earlier, we define the tumor volume. We have to know where is the target, where would it possibly spread, like the lymph nodes and its surrounding structures. And then from there, from defining the tumor volume, we would deliver a homogeneous and adequate dose to the target volume. Okay, so that's why there is, for any other cancer, we have a certain dosage that needs to be given to these patients. So deliver a homogeneous and adequate dose to the target volume. Then we keep the dose limits of normal tissues or organs. Okay, so these are the organs at risk, and control the side effects. Okay, with the side effects of radiation, it would depend on the area being irradiated. So if you're treating the head and neck area, then the patient could have like what we call xerostomia, or the saliva would dry up and mucositis. Sometimes they would have mouth sores. Okay, but if the patient is being treated at the abdominal area, then the patient could have bloatedness and could have diarrhea. So the side effects is actually dependent on the area that is being treated. It is not just not all patients would have the same side effects. Okay, so again, we define the tumor volume, we deliver a homogeneous and adequate dose to the target volume, we keep the doses to the normal tissues or organs within its limits because normal tissues would be able to receive radiation and they can tolerate radiation, but we do not, we should limit the dose to that normal tissues to the dose limits and control the side effects. Okay, so when do we do radiation therapy? There are several strategies for giving radiation therapy. Sometimes we give radiation therapy preoperative, so meaning before the patient undergoes surgery. So this is now being done for patients with the rectal cancer, with colorectal cancer. Patient undergoes radiation therapy plus chemotherapy. Then after 6 to 8 weeks, the patient would undergo the surgery. Okay, then we have postoperative. Postoperative means patient has already undergone surgery, and then after that, patient would be referred for radiation therapy. So we usually use this for, let's say, head and neck tumors. For example, if the patient undergoes glossectomy for tongue cancer, so the part of the tongue would be taken out, after which the patient would be referred for us for radiation therapy. Also, post-chemotherapy, meaning if the patient has already undergone surgery, for example, for breast cancer, so the patient would undergo modified radical mastectomy wherein they remove the breast, then the patient would undergo chemotherapy, then after that, the patient would undergo radiation therapy. Or concurrent with chemotherapy, meaning radiation and chemotherapy are given at the same time. This is because there would be a synergistic effect between chemotherapy and the radiation therapy. So the chemo and the radiation would help each other. So we usually do this for, let's say, nasopharyngeal cancer, patients with cancer at the back of the nose. We treat that with chemotherapy, wherein it is given every 21 days, and then radiation therapy daily, Monday to Friday, for 35 sessions. We also give concurrent chemotherapy for patients with cervical cancer. So patients with cervical cancer, we give radiation therapy daily, Monday to Friday, and the patient usually undergoes chemotherapy in every week. Okay, so that is the concurrent with chemotherapy. Or sometimes patient would receive radiation therapy alone. Let's say for patients with laryngeal cancer, for patients with prostate cancer who are not candidates for surgery or who opted to undergo radiation therapy. So we can use radiation therapy alone for prostate. We can use radiation therapy alone for larynx cancer. These are, or if the patient is not amenable to undergoing chemotherapy and is not a good candidate for surgery, then you can use radiation therapy alone for these patients. Okay, so what are the two types of radiation therapy? So we have an external radiation therapy wherein the radiation would be coming from a machine outside and go into the patient. So we have presently we have three machines for this. We have a Cobalt 60. This is the old machine. We have a linear accelerator, and we have the tomotherapy. And we also have an internal radiation therapy, or what we call brachytherapy, where we have two kinds. We have a low dose rate and a high dose rate, wherein we put radioactive sources inside the patient's tumor. So, what is external beam radiation therapy? Okay, so this is what a Cobalt machine looks like. So this Cobalt machine has been in use since the 1950s. We have a radioactive source inside this head, and radiation would be coming out from there and treat the patient here. So this can go in the front, in the back, and in the sides. So this is we usually the Cobalt machine now is only present in a few government hospitals, and it's actually being phased out and being replaced by the linear accelerators. So this is a linear accelerator, or what we call a LINAC. Okay, so same, we have a radiation source here. The source is not actually a radioactive source, but it's just like an X-ray. So when the machine is turned on, the radiation beam would be hitting the patient, the target, and then it can go from front to the back to the sides and can go around the patient. So this is a linear accelerator. And we also have the newer machines, which is the tomotherapy. Okay, this is an accurate tomotherapy. It's like a CT scan, wherein the patient would go inside and be treated at a helical manner. So the radiation would actually go around the patient. So these are the newer modalities. So this is an example of a helical intensity modulated radiotherapy treatment, wherein the machine would be going around the patient and treat the patient's tumor in a helical manner. So the present machines, the linear accelerators and tomotherapy machines, have a multi-leaf collimator such as this, wherein it already conforms to the shape of the target. Whereas before, this is just a square or rectangular collimator, and we have to use lead blocks to protect the organs. But with the newer machines, these multi-leaf collimators, these are actually the leaves of the multi-leaf collimator. They can increase and decrease in size depending on the targets, on the patient's target, on the tumor. So these are the multi-leaf collimators that would move in and out of the patient, and depending on the contour and depending on the target. So the shape would okay, so that is the multi-leaf collimators. Now, how do we do, or what is the process of external beam radiation therapy? So first of all, the patient would come in for consultation. So we would assess the patient. We would see if the patient is suitable for radiation therapy, ask for laboratories. And then if it's already scheduled, then patient would undergo the CT scan planning. Okay, in the CT scan planning, the patient would undergo immobilization so that the patient would not be able to move during the radiation therapy, and this would promote precision and accuracy in the radiation therapy. So after doing the immobilization, the patient would now undergo a CT scan simulation, and then after the patient undergoes the CT scan simulation, we will have the images in our computer, and from there we would now delineate what is the target, which are the areas that we need to treat, and also what are the organs at risk or the areas that we have to avoid. Then after that, we will have a stereoscopic planning and a computer planning. So based on the target delineation and on the organs at risk, we would be giving a dose for these areas, what the target needs to receive, and also the surrounding areas, and what are the at-risk organs, the organs at risk, what are the doses that they should be receiving or below those doses. Then after approving the plan, we would now deliver the radiation and have the daily treatment. So the dose delivery, we do this every day, so Monday to Friday, and the patient would have, depending on the kind of cancer, the number of sessions for the radiation. So for example, for breast cancer, it is usually delivered in 30 days. For cervical cancer, for 25 to 30 days. For head and neck cancer, we usually give 35 sessions. For prostate, around 36, 37 to 40 sessions of radiation. So it is not the same for every other cancer. So the number of sessions would depend on the type of cancer and on the area that is being treated. And then while the patient is undergoing radiation, so it's for about as short as 10 sessions to as long as 40 sessions, patient would be assessed on a weekly basis, and then we will have the outcomes and then a follow-up. So in the process of radiation, this is the first step. Okay, we will have the CT planning before the patient undergoes CT scan. there should be an immobilization. So this is what we call a thermoplastic mask. So the patient would be fitted with this mask during the planning, and it would conform to the shape of the patient. So this would immobilize the head and the shoulder part, okay, so that the patient would not be able to move during the radiation. Because, for example, if we are treating the area here of the nasopharynx, at the back, if the patient would slightly move his head to the left or to the right, we could already be hitting the eyes of these patients or the brain of the patient. So we have to immobilize them. Okay, but as you can see, the patient can actually breathe through these masks, no? So they can breathe here, and they could also see that they can open their eyes and see, but we usually just ask them to close them. Okay, and also the shoulders would not be able to move because we usually treat also the neck area. So another type of immobilization is what we call a vacuum lock. Okay, so we use this for example, for prostate cancer, for cancers of the stomach, or cancers of the colorectal area, or for women, cervical cancer. Also, we can use this for cancers of, let's say, the extremities. No, so this would the patient would lie down, and then a vacuum seal would conform these blue bag to the shape of the patient. And the patient would now be using this for the next 25 to 30 sessions. So this is another immobilization device. We usually use this for breast cancer. So it's a breastboard with the patient's arms would be placed here and the head would be here. And that would immobilize the patient's upper extremity. Okay, so after doing the immobilization, now the patient would undergo a CT scan simulation in the position wherein the patient would undergo radiation. So the positioning of the patient during the CT scan simulation is critical because this would be the same position that the patient would be using while the patient is undergoing the radiation therapy. Okay, so after doing the CT scan, we will have now the images. And in the images, we will now delineate the target. So for example, here, so this is the target. We have the tumor here at the area of the nasopharynx and going into the nasal cavity. So we delineate where the target is, and we also have a margin for the target. Okay. Then after that, we would also be delineating the organs at risk. So for example, for these patients, the organs at risk would be the eyes, the optic nerves here, and of course, the brain. So we will have to delineate also those areas. Okay. So after delineating the organs at risk, we would now be giving a prescription, a dose prescription. So for example, for this breast cancer patient here who has undergone mastectomy, so you see that there's already no breast here. That is also already the soft tissue and the skin. So this is the target area. We would now be giving a dose of 50 to 60 gray in 25 to 30 fractions. Okay, but of course, when we're doing the planning, we have to avoid the normal structure here, which is the lungs, and here the heart. Okay, of course, the spinal cord and the esophagus. So that is the value of doing CT scan planning. So when we have already given a dose prescription, the medical physicist, who is our partner in doing these radiation therapy beams, would now create beams to target these areas and avoid the normal structures. And after we have already approved the plan, okay, so for example, here's another one for head and neck. So there's the target, avoid the eyes, and avoid these this parotid gland, and then avoid the part of the spinal cord. Okay, so these are the parotid glands. So the target would be encompassed, the dose would be encompassed in the target volume. Okay, so after that, this is also an example wherein we treat this tumor here in the lungs and give a dose prescription for this area. So after we have evaluated and approved the dose, then the patient would now undergo dose delivery and daily treatments. Okay. So for the dose delivery and daily treatment, so the patient, for example, here being treated for the breast, this is the position in the planning, and this will also be the position in the treatment. So the patient would not go inside the machine and have the breast treated. Okay, so for daily, Monday to Friday. So the treatment itself is for about, it can be as short as 15 minutes to sometimes 25 to 30 minutes, so depending on the site. And this would be from Monday to Friday. No, so the Saturdays and Sundays are usually reserved for the repair of the normal tissue. So there's usually a break during the treatment, and it would be for about 2 weeks to 4 weeks to 5 weeks to 6 weeks. So depending on the site, as I have mentioned earlier. So for breast, it's usually for about 6 weeks, the radiation therapy. And it is important that the patient undergoes the daily treatment for it to be effective. No? So it's usually on a daily basis. Okay. Now, during the treatment, the patient would undergo a regular assessment by his or her radiation oncologist. And we usually check the patients on a weekly basis, assess the side effects having after during the treatment, also assess the, we usually ask for a blood count and sometimes a blood chemistry to monitor these patients, because of course there would be some side effects of the treatment. And the side effects would depend on the area being treated. So, for example, if the patient is undergoing radiation therapy on the head and neck area, the usual side effect of that would be what we call xerostomia, or dryness of the mouth. The patient would also have some desquamation of the area of the neck, meaning it's like patient is having sunburn. Of course, the sun is radiation, and this is radiation therapy. So the cumulative radiation would have an effect on the patient's skin. There would be dryness of that area, and sometimes it would look like a sunburn. So we manage that. If the patient is undergoing radiation for the colorectal area, the patient can suffer from epigastric pain. The patient can also have bloatedness and could have diarrhea, so we manage that. Now, after all the treatment has been done, 30 days, 35 days, then the patient would have a schedule for his regular follow-up. And during the regular follow-up, we would now assess the effect of the radiation. Okay, so that is external radiation. Now, what about internal radiation, or what we call brachytherapy? So brachytherapy means from a short distance, wherein we use applicators where we place the radioactive source close to the tumor or within the tumor itself. And there are four kinds. You have superficial, wherein the tumor, for example, is in the skin. We have intracavitary, or in the cavities of the patient, such as, for example, in the cervix. We have intraluminal, wherein, like, for example, in the esophagus or in the lungs. And we have interstitial, wherein we have to put needles inside the patient to target the tumor. So this is a high-dose rate brachytherapy machine. There's a radioactive source here. And if you would notice, there are outlets here wherein the radiation will be coming out and going inside the patient using catheters. The main, around 80% of patients undergoing brachytherapy are those with cervical or endometrial cancer. And these are the applicators that we use, the usual applicators that we use for treating cervical cancer patients. If you could see here, this is the vaginal canal, and you have here the uterus, and an instrument is placed inside the patient's vagina and into the intrauterine cavity. Okay, so this is an example of a Fletcher applicator, and this is a Henschke applicator. This one is what we call a tandem that is placed inside the patient's, this one is placed inside the patient's cervix into the uterus. So this is the one. And then we have the ovoids that are placed into the vaginal canal and treat the patient's cancer here. So we do this under anesthesia. So it's either spinal anesthesia or a general anesthesia. And the patient, we would place an applicator inside through the patient's vagina, going inside the patient's uterus and here in the vaginal canal, and treat this area. Now, we usually do this after external beam radiation therapy for cervical carcinoma because we have to decrease first the size of the tumor, and then this would be the final treatment. So we usually do this for about 4 sessions. It's usually done once a week, about 2 hours per session. So another example, so these are the applicators that we placed inside the patient's uterus and vagina. And you have here the target, you have here the dose distribution. So another example, this is a nasopharyngeal carcinoma. The cancer is here at the back, the left side of the nasopharynx. So this is the nose area. So patient undergoes 35 sessions of radiation, and after 35 sessions, you would note that the tumor here is already gone. Okay. So during the treatment, we have to protect the ears, we have to protect the spinal cord, we have to protect the parotid glands, okay, to minimize the side effects. So this is 35 sessions of radiation therapy. So this is another patient of mine way back in 2006. The patient presented with a huge anaplastic carcinoma at the neck area. So it's here, big, it is bleeding, it has discharges. So patient underwent 35 sessions of radiation, and this is the progress. Okay, this is around at the 15th day of radiation. Okay, and this is around the 30th day of radiation. On the 35th day, actually the patient still has a residual tumor here. Okay, there's still a residual tumor. So the patient asked me what he will do about it. So I just told him to go home and rest and come back to me after 1 month. Usually radiation therapy has an effect even after the patient has already completed the required number of doses of radiation. And usually the effect would still last for about 1 to 3 months. Okay, so there would still be an effect of the radiation. And as proven here, after radiation, patient comes back 1 month after, and you will see that the tumor has already gone and this is starting to close. Okay, so this is the post-radiation therapy for this patient that presented with this huge mass. Okay, so 1 month after, the tumor is gone. Okay, thereby keeping the patient's hair. Okay, so with the tomotherapy machine, we can now actually do that, scalp sparing radiation therapy. Before, for all brain metastasis, no, for cancer that has spread to the brain, if it's just 1 to 5, before we have to treat the whole brain. We have to include the whole brain area. But now we have what is called a stereotactic radiosurgery or a fractionated radiosurgery. It is not actually surgery, but wherein we do not need to open up the patient, but we can actually take out these metastatic sites and give from 1 session to 5 sessions of high dose radiation safely to these areas. So with the stereotactic radiosurgery and the stereotactic radiotherapy or fractionated radiosurgery, we can now treat these tumors better than before and give the patient a high quality of life, not treat the whole brain area anymore. So that's what we call SRS or SRT. Okay, so what about survival rates? So you have now seen that radiation therapy can be given together with chemo or surgery to provide a better chance for these patients. But for all cancer, the survival rates would actually depend on the stage that the patient is in. Okay, so the earlier the stage, the better chances of cure and survival. The use of multi-modality treatment also improves survival. So we use surgery, we use chemotherapy, we use radiation therapy, and all of this would improve survival. Now, the type of cancer and the location in the histopathology also affects survival. Okay. For example, if you have a patient with a laryngeal cancer, a vocal cord cancer, stage 1, okay, the usual treatment for that is surgery. But some patients do not want surgery, and patients could now they have a choice between surgery and radiation therapy. So this is for stage 1 and stage 2 vocal cord cancer. And the survival rates for these patients could be as high for surgery and for radiation of about 95 to 98%. Okay. Another example is for cancers of the prostate, wherein patient would undergo radiation. Okay, so it is equivalent to the survival rates for patients undergoing radical prostatectomy. You have, of course, depending on the stage, if it is stage 1 or 2, you have around 90%, 95% survival rates for this. Now, in general, if the patient has an early stage, stage 1, the survival rates could be as high as 90 to 95 to 98%. If the patient would be on the stage 2, then the survival rates would be around 70% to 80%. If it's stage 3, then that would go down to around 50 to 60% to 70% at the most. And if it's stage 4, of course, that would be the last stage. There is still a possibility of survival of about 20% to 30%, depending on the patient's response to the treatment. Okay, so these are general, no, but the survival rates would of course vary depending on the cancer type and the location. So, will I lose my hair once I undergo radiation therapy? No, you will not lose your hair while undergoing radiation therapy. The effect of radiation only depends on the area that is being treated. So, if we are treating that area of the head, okay, then the patient can lose her hair. But if we will do the scalp sparing technique, then the hair need not be gone. Okay. So the effect again of radiation would depend only on the area that is being irradiated. Okay. Now another common misconception is that radiation therapy is painful. They say that when you are being irradiated, it's like being burned. That's not true. Okay, that's really not true. Actually, radiation therapy is a powerful tool for treating painful sites. So that's why patients who have bone metastasis or cancer that has spread to the bone area, these patients undergo radiation therapy. And 80% of the time, we are able to decrease the patient's pain and provide a good quality of life. So that radiation therapy is painful is not true. There is no pain. Well, the patient does not experience any pain. It is not. There is no pain at all while the patient is undergoing radiation. It's just like the patient is undergoing X-ray. Okay. So again, the radiation would be given on a daily basis. It's from Monday to Friday. You have a break of Saturdays and Sundays, and usually on the holidays. The radiation would be for about 15 to 25 minutes on a daily basis. The patient would have to go every day, okay, and then after that they could come home, and they are not radioactive, okay. And the patient would need around 25 to 30 sessions, and sometimes as small as 10 sessions for these treatments, okay. So, as a doctor, this has been our mantra from Hippocrates. We can cure sometimes, we treat often, but we have to provide comfort always. Of course, not all cancer patients would survive, but with the multimodality approach and with the new treatment modalities that we have, we can cure them sometimes, we treat them often, but we always provide comfort for these patients. Thank you very much for having me.